Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon, and I'm the chair and organizer of Grand Rounds. And today I'll be speaking at Grand Rounds as well, along with Arlene Shaw, who sat just right next to me, waiting in the wings to come and bail me out when things get tricky. So, as I said in my email, I ask every week if people will come and speak at Grand Rounds, and it dawns on me that I am somebody, so I should come and speak at Grand Rounds as well. And I've only spoken a couple of times, but it is nice to be able to have to come along and speak about something which is important to me as an asthma specialist, but is something which will touch on all of us clinically because asthma is such a common thing, such a common disease, that it's unfeasible that you don't know somebody with asthma. A third of the people in the virtual room will have been prescribed an inhaler at some point in their life for a wheezy illness or for asthma. So it's incredibly common. So I think and we wait for as evidence builds and then guidelines come out, and oftentimes things change in an incremental way. But in November of 2024, there was a real massive change in how we treat, diagnose, manage asthma. And I think it's an important thing to come and talk about to share with everybody. I have a whole raft here of disclosures, if I can move my slides on, because I've spent the last 20 years being involved in asthma research and asthma drug development. So these are my disclosures. I've worked with a number of different companies through the years to try to improve asthma care, and I chair the asthma precision group for Scotland and sit on the UK and worldwide groups. And I now chair the Scottish Severe Asthma subgroup for CFSD. So that gives you some context to where I'm coming from. So asthma's not going away. It's a disease which, as I've said already, affects about 30% of people in Scotland. And the proportion of people who get prescribed an inhaler is even higher than the number of people who are given a diagnosis of asthma. You could argue that both of those should be the same thing. The number of people with an asthma diagnosis has leveled off a little bit since 1990, but is still high. But concerningly, the number of people who die from asthma, although there was a trend from the 1990s coming down, you'll see this split around 1995, where women, the rate of death in women is not decreasing as rapidly as it is in men. And now there's quite a significant disparity between male and female mortality in asthma. So this is very worrying. We don't fully understand why more women die than men from asthma, but we suspect it's due to catamenial worsening of symptoms. And that is an area of interest for us locally and across Scotland as we try to work out, working with our endocrinology colleagues, what it is about hormonal changes of pregnancy, breastfeeding, menopause that lead to changes in asthma care, but we don't know. But the point is, this is not a trivial disease. It's not going away, and it still kills people. A very interesting observation is that asthma is a diagnosis of affluence, and that people in socio-demographic index, high index, have a higher incidence and prevalence of asthma. Yet the people who die from it are people with low socio-demographic index scores. So if you middle and upper middle class families will have more asthma in them, but overwhelmingly it's people from lower class, working class backgrounds that tend to die from asthma. And all the rates are coming down slightly, but not really. And again, something that we've really not managed to tackle in the last 40 years. And one of the issues is that, sorry, there is a chat. Oh, Sarah is asking me difficult questions in the middle of a talk. I'll come back to you, Sarah. So one of the challenges is that this is the medical school library where I went to, where I think I may have walked into this library once and walked out again. But this is where I studied medicine. And we were taught asthma in a straightforward way. It was brown inhaler, blue inhaler. And the brown inhaler is your preventer and the blue inhaler is your reliever. And that's kind of it. And there have been some changes in what color inhaler we give to people, and there's some combination inhalers that we give to people as preventers. But the general public, most people will appreciate their appreciation of asthma is brown inhaler, blue inhaler. And if you feel bad, you take your blue inhaler. And if you remember, you take your brown inhaler. There are some research looking at the poverty angle that if you have to pay for your prescriptions and you have to pay individually for your brown inhaler, your blue inhaler, and you can only afford to buy one, then you buy the blue one, you don't buy the brown one. And we know, and I'm going to show you some evidence that that's a really, really bad idea. Quiz time. Does anyone know what year this was? This makes me feel very old when you look at that films like Snowpiercer, Guardians of the Galaxy. When was that? What year? Dave, who's put his head around the laptop and still doesn't want to guess. This was 2014, believe it or not. So that makes me feel very old. So what happened in 2014 was that there was a national review of asthma deaths. This was commissioned by the Royal College of Physicians in London and HQIP. And they looked at every asthma death across the whole of the UK and did a thorough review of what led to that death. And there were Scottish deaths in that. And these are some of the headline results that during the final attack of asthma, 45% were known to have died without seeking medical assistance or before medical care could be provided. Which perhaps even more worryingly is that 55% of people did seek assistance but still died anyway. So people don't present with severe asthma because they don't have an understanding of how bad it is and how the risk of dying. And when people do present, it's often too late and there's nothing much we can do. 57% of people were not under specialist supervision in the previous 12 months. And we know that people don't turn up to their follow-up appointments. They don't turn up to primary care. They don't turn up to secondary care. It has one of the highest DNA rates of any of the clinics we do in respiratory medicine is the asthma clinic. Yet over about a half of people had previously been admitted to hospital. So they are people who are exacerbating. They have a high symptom burden. They don't attend to follow up and they don't tend to present early. A tenth of them died within a month of being discharged from hospital, and a fifth of them had emergency hospital ER, ED department care, and over half had been there more than twice or more. So these people are presenting in an acute way, and the signal is there. Only a quarter had a personalized asthma action plan. That number is worse locally. It's about 10% rather than 23%. And almost half had not had an asthma review the previous year. 50% of cases, there was no documentation of what made their asthma worse. 60% were documented as having non-severe asthma. So that is that no one had appreciated the severity of their asthma, that they were likely to die. And it was felt that death was avoidable in 2/3 of these cases. And half the time, evidence-based guidelines were not followed. Martin Partridge, who was professor of medicine, respiratory medicine at Imperial College at the time, he wrote this in his editorial of it. Do not forget it concerns people who have died, many needlessly and many prematurely, leaving anguish and heartbreak for their loved ones. The best result from this report will be that its recommendations are implemented and a further review of asthma deaths will not be required because fewer people die from the disease. And it saddens me to say that we're about to start the next review of asthma deaths in Scotland, either this year or next year, because we have a strong suspicion that this situation has not really changed. And the asthma guidelines show us very clearly who is at highest risk of dying from fatal asthma. And it's people who've nearly died before, people who've been admitted frequently, people who've had are on lots of different drugs for their asthma. But this one here is really important, and that is the people who have heavy use of beta agonists. And I'm going to just make my pointer work here, hopefully. So heavy use of beta agonists. So people who are using their blue inhaler but not their brown inhaler. And we've known this for a long time. I'm going to briefly go through the evidence for that. But also people who attend ED, people who go to out of hours, people who present to their pharmacists to get blue inhalers because they've run out, people who don't engage in the standard framework of asthma care. And then all of these in the bottom here are really interesting features. Many of them are associated with poverty and deprivation, and the things that we know lead to increased risks, things like learning difficulties, alcohol abuse, denial, abuse of many sorts, and long-term enduring psychiatric illness. But it can be hard, despite knowing all this, it can be very hard to engage people in any asthma services. The asthma guidelines, this is ripped from the asthma guideline from 5, 6 years ago. Just to remind you that asthma is not a particularly straightforward thing to diagnose. There's not one single test that you can do. It's an amalgamation of symptoms which are suggestive of asthma, along with some tests which might be suggestive, and then a test of treatment. I do point out that for the last 10 years, the trial of treatment for asthma has been inhaled corticosteroid, not a short-acting beta agonist. Yet, I'm going to show you in a bit that a fifth of prescribing of salbutamol in Tayside is to patients who are not on an ICS. So about a fifth of people are on SABA only for their asthma, despite the fact that that has not been in the guidelines for over 10 years. This is the stepwise guide to how you treat asthma from the previous BTS guidelines. Again, just to say, if you suspect asthma, you should give an inhaled corticosteroid. If you definitely think they've got asthma, give an inhaled corticosteroid. And then all this ramp up of treatment that goes into adding long-acting beta agonists, long-acting antimuscarinics, and then consideration of leukotriene receptor antagonists, uniphylin, LAMAs, all sorts of things, until you finally reach high dose steroids, and then you get referred to see someone in the hospital. This has been the dogma for asthma for 20 years. This is how you do it: brown inhaler, blue inhaler, and then you change to purple inhaler, pink inhaler, white inhaler, and then add in some tablets. The problem with this is that, as I've said, people overuse their salbutamol. They preferentially take their salbutamol. They don't take their preventative medication. And we've known for almost as long as I've been alive that excessive use of beta-2 agonists is not only detrimental but life-threatening. So much of this evidence came from New Zealand in the early 80s, where Richard Beasley and his team looked at the amount of phenoterol, which is their beta-2 agonist of choice at the time, and rates of death. And this is quite a famous graph in asthma circles, where if you look at the number of canisters of salbutamol or any short-acting beta agonist that you take and look at your death rate, once you get to 2 canisters a month, your death rate starts to really climb. The converse is true with taking inhaled corticosteroids, that the more corticosteroid you take in the year, the less likely you are to die. This evidence base is very strong. It's been repeated. This is from the middle one is from the early 80s, then there's the late 80s, then there's the 90s, and there's data from the noughties to really ram home the point that excess SABA usage leads to increased mortality in asthma. This is a paper from 1992 in the New England Journal of Medicine, which, just if you're interested in odds ratios, this is really quite a powerful thing. That if you're in the first model, they use any beta-2 agonist, for every canister you use per month, then your odds ratio of either dying or ending up in ICU goes up significantly, and your risk of death is very, very high. And they split this out into phenoterol and albuterol, just to look at the 2 different types of beta agonists that they used in America at the time. And these odds ratios are really quite frightening, that if you're on more than 25 salbutamol or phenoterol inhalers in a year, and we have plenty of patients who pick up a salbutamol inhaler every 2 weeks, that is not out of the ordinary at all, then your odds ratio of dying is very high. Let's say that. What does it look like in Scotland? This is data from the Quality Prescribing Strategy Improvement Guide. This data shows you from 2021, 22, and 23, and we can compare ourselves against the other health boards. So this is the number of people who get 6 or more SABA inhalers out of all SABA inhalers, and Tayside is somewhere in the middle here. But a third of people with asthma are getting at least 6 inhalers a year, and ideally they should get 1. And this is SABA only. So people who are getting only SABA without any ICS at all, and this should be 0 for asthma, and it is 20%. And that's kind of flat across the board. So despite all this weight of evidence, we're still giving people salbutamol by itself. Now, the global organization, which is GINA, for a long time have given two different approaches to treating asthma. One is to use a controller reliever, that's track two, so brown inhaler, blue inhaler. But their track one here is controller and reliever in a single inhaler. So they've proposed for a long time to use a low dose of inhaled steroid plus formoterol in a single inhaler and use that as your maintenance therapy and your reliever therapy. Now that's called MART, and that's been part of our options for many years, maybe 10 years or so, that we could use MART. But there's now been a big change in how we treat mild to moderate asthma beyond MART. Oh, just one final point before I hand over to Arlene is the environmental impact of inhalers. This is an important thing for all of us, global warming potential and the like. That metered dose inhalers provide a significant proportion of the total global warming potential and carbon footprint for the NHS. And you think, well, it's just an inhaler, but we're prescribing so many inhalers over such a large proportion of the population that this really adds up. But this infographic kind of helps give you an idea that if you're on some of the really bad inhalers in terms of global footprint, like Flutiform or Symbicort, then this is one inhaler is equivalent to a 150-mile petrol journey. Whereas if you're on a dry powder inhaler or a soft mist inhaler, then that's way, 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 way down. So there's a massive change between which kind of inhaler you choose, something which isn't always at the forefront of people's minds, but it is at the forefront in part of the new guideline. So this new guideline, which I've mentioned a few times, was published at the end of November of last year. We've always had a nice guideline for England and Wales. We've had a BTS sign guideline for Scotland and England and Wales. And then we've had the GINA guideline, which is a worldwide process, and they've never agreed with each other. So for the first time ever, the BTS, British Thoracic Society, NICE and SIGN all came together to agree on the same guideline for asthma, and it was published at the end of last year. The guideline only deals with diagnosis and pharmacological management. All the rest of it is still the old guideline, or we're working on updating it. So that's a work in progress. Angela Timoney, who chaired the SIGN Council on this, presented at the British Thoracic Society winter meeting, and she and I, as national leads for this, have been trying to push out the guidelines across the country, across Scotland at least, in the last 6 months or so. I'm going to pass on to Arlene, who's going to talk a little bit about this bit. Or do you want me to talk about this bit? Oh, I'll talk about diagnosis. Well, I'll talk about diagnosis. And then she can talk about treatment. Okay. So you can remember that there was that complicated diagram in the previous guidelines. And this is the diagnostic pathway for adults and young people over 16. And the order of the tests that we do when there's a clinical history of asthma is now blood eosinophils or an exhaled nitric oxide, which we call FeNO, as the first line test. So you may have in your head, we're going to do a peak flow diary, but that is the first line test is high eosinophils or a FeNO. And if either or both of those are high, that's so strongly suggestive of asthma that that's enough for the diagnosis. Bronchodilator reversibility with spirometry as second line. And I appreciate that is challenging to get in primary care here in Tayside, something we're working on. It's a Scotland-wide issue getting spirometry done, but that's something we're aware of. And if you can't get hold of that, then a peak flow diary with variability testing is a reasonable thing to do. And then the guideline says at the end you can go on to a bronchial challenge test, which is only really available in secondary care. There's a nice straightforward, have you got eosinophils? Have you got a high FeNO? Is there reversibility? And if you have any of these, then you can move on and say that you've got asthma. And this is so much more straightforward than the previous guidelines, and I think is really, really welcomed. But it does mean a shift in thought of processes to looking at eosinophils and looking at FeNO. I'm not a pediatrician, but there are pediatric bits in this. So the algorithm for children aged 5 to 16 with a history suggestive of asthma is very similar. It doesn't have eosinophils in it. I suspect this is to avoid doing phlebotomy in young children. But FeNO is such a straightforward test to do that it can be done by young children of primary school age and perhaps even younger than that. Bronchodilator reversibility is quite tricky in young kids, but it is possible. But peak flow diaries are more straightforward. And then at the end, skin prick testing to look for allergy, or finally a blood test can be utilized. So This is a straightforward diagnostic algorithm for people who've got an illness suggestive of asthma, i.e. breathlessness, and importantly, wheeze. Do you want to talk about this bit?
I can do.
You can talk about this bit, or just a
Do you want to
swap around?
My own camera.
Yes, you're on camera. Yes, you're on camera.
Need to come down. Okay, so this is the excerpt from the updated guideline, which summarises the treatment recommendations that are now put forward around asthma. So on the left-hand side, we have the sort of traditional model with the reliever and preventer, but the new guideline is the focus on the right-hand side of the screen. So for any patient who's newly diagnosed with asthma, the first line treatment is to offer a low dose inhaled corticosteroid formoterol combination, and we take that as AIR, which is anti-inflammatory reliever therapy. So they use the one device only as and when they need to. The advantage of that is that every time they take a reliever dose, they actually get an inhaled corticosteroid, so we're treating the inflammatory element of the disease that's underlying there. And what the evidence shows us is that if we use this in patients with mild to moderate asthma, then they probably use on average about 2 inhalers a year. If the patients need it more frequently than that, then what we have is two options, and it's the low dose MART, which is one device that they take one puff morning and night, and then they also use the same device as and when required for symptom control. If they're getting symptoms and they're using that breakthrough dose quite often, they can move up to the moderate dose MART, which is your 2 puffs twice a day and as and when required. All with one single device, so there's no differentiation between reliever and maintenance devices. Obviously that makes it hugely simpler for the patients, but it also means that we're teaching one inhaler technique. There's not this disparity of different devices with an MDI for your reliever and a dry powder for your maintenance treatment that we know exists in reality. And it's only really after we exhaust the ICS LABA options that I've described there that that patients really should be referred into a specialist centre if they're still not controlled at that point. And it's only really after that then we start thinking about adding the leukotriene receptor antagonists or your LAMAs or any other agents. But the key at that point is to get them into the specialist centre to look and see so we can optimise their treatment. So locally, we need to think about how we implement this. We've probably got about 30,000 asthma patients in Tayside, and obviously we can't switch everybody overnight. So we've had to look at an implementation strategy around delivering this locally. We reckon it'll probably take about 3 years to do a full transition, but we need to think about how we do that and do that in a sort of risk stratified way. So new diagnosis, they're probably the easier group. So for any newly diagnosed patient, and I'm speaking about adults here, but pediatrics are coming along this path as well, but I'm not going to speak about them today. That's out with my scope. But any newly diagnosed patient with mild disease would be started on AIR, so a LABA ICS, never a SABA, so they wouldn't be given a salbutamol. If they had moderate disease, then it would be MART, so that regular LABA ICS with PRN in the same device. At the moment, we only have a DPI option, so a dry powder inhaler, and it's only for formoterol in terms of the LABA that we have available to use in this approach. So if the patients required a MDI or they couldn't use a DPI for any reason, then we would look at the alternative formulary recommendation. Tom's already spoke about eosinophils and pheno, so I'm not going to say any more about that. But the sort of bigger challenge, I suppose, locally is the existing patients that are out there. And as the data shows us, we have some quite significant risk out in our population. So we need to think about the opportunistic switching of these patients. So those that are prescribed SABA only at the moment, so about 20% of our population, are at significant risk, and they're probably our priority in terms of converting them over to either AIR or MART, depending on the severity of their disease. And that allows us to ensure that they're getting inhaled corticosteroid as part of their treatment and not solely relying on the SABA element. There's other groups there. There's patients that will work down the sort of risk list, if you like. So there's patients who overuse SABA. That's probably our next priority. So there are a cohort of patients who are prescribed an inhaled corticosteroid but choose to not to use it and rely and choose to only use the SABA, or particularly overuse the SABA. So again, we know from that data, and Tom's already mentioned, that there are patients out there who are getting 30, 40, 50 SABA devices a year, and which is really quite concerning. So that would be our next sort of priority group. And then followed by our patients who are not fully complying with the inhaled corticosteroid or their background treatment. Really it forces them to use the ICS, if you like, when they need. There are patients who, if they're controlled on fixed dosing, so the previous approach to treatment, then some of them may not wish to switch, or it may not be appropriate to switch, but there will be some that will be appropriate to switch, and they will be a focus of our attention probably in next year. So this is my very, 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 very slimmed down version of the nice BTS sign recommendations with our local twist on it. So we do now have approval that our inhaler of choice for both AIR and MART as a dry powder option will be Symbicort, but hopefully this shows you just how simple it is. That it's one device, and as I say, as required for mild disease, or regular and as required for severe disease. And essentially what we're saying to the patients is take the Symbicort when you need it and don't when you don't, which is a very different message to what we've done for many years, but hopefully that's much simpler for them, and I think what a lot of them do, and that's why we probably got to the position that we are with the SABAs. Just important to highlight that patients can step up and down as they need to. So they're not fixed on MART or fixed on AIR. They can be on MART for a period of time, and then they can potentially step down to AIR or step up. And again, keeping the same device consistent throughout has several advantages there. If patients do need an MDI or they can't use the DPI alternative, so we know from the prescribing data at the moment we're big MDI users in NHS Tayside. We don't have an AIR option in an MDI at the moment, but we do have a MART option, and that would be Luforbec, which is the branded generic for Fostier. So Luforbec works exactly the same in terms of the MART, in that we can use the lower dose MART or higher dose MART with Luforbec, and that can be used with a spacer. In terms of the referral into specialist care, so I think there's quite there's a misperception of what that actually means. So a specialist in asthma care can be any healthcare professional with higher training in respiratory medicine and who is competent in managing asthma. So I think the myth is that it's a consultant, or it has to be Tom or one of his colleagues, but actually there's a big team of asthma specialists, and they're not all based in the hospital. So we think widely of specialists in asthma care. This is
me, or is it you?
I'll do this one.
Yeah,
and then
go
I'll
for
let
it,
you
yeah.
go. So this was the MHRA warning, which has a similar one has been in existence for many years, but just reiterating the risks associated with overusing the SABA. But this was republished in April last month, just to highlight the fact that the new guideline exists, and actually this is a great tool to help address this issue, because we can use we don't have to use a SABA on its own now. We can use SABA ICS as a treatment strategy for asthma. So I think that recognises how important this issue is. I'll let Tom.
Super.
Next.
Thanks so much. Chair back up again. I think my animation's gone a bit wonky. So thank you very much to Arlene for doing that. I just acknowledge how much work Arlene has put into the implementation of this over the last years. To be honest, it's certainly been a busy 6 months for us behind the scenes, but it's been able to amalgamate this to something so straightforward is something that no other health board has been able to do as yet, at least. And for us, the really key thing was simplicity. And if someone can just have one inhaler, so they know that how to use that one inhaler, they can step up, they can step down. That's really helpful. But also for the non-specialist asthma folk, to be able to have something straightforward that says, yeah, now I know understand about asthma. I know it's just one inhaler. It's not brown inhaler, blue inhaler. It's one of these. It's just this white and red thing. And if you know how you only have to know how to use one inhaler device. And there are trainers. These are the whistles, and all you have to be able to do is suck on it to make the whistle. It's not really a whistle. It's like a reed. And if you can do that, then you can take a Symbicort inhaler. And there are demo devices that are available very easily to get hold of. And this is how simple it is that if it's a new diagnosis, then you go on to Symbicort as AIR into MART. For those with existing diagnosis, if it's SABA only, we want to get people onto AIR and MART. SABA over reliance onto AIR and MART. Poor control can try that as well. And then, of course, there's patient choice. That people may hear about this. There's quite a lot of publicity from Asthma Lung UK and Chest Heart Stroke Scotland. So patients may well know about this, and they may come knock on your door and say, can I change my inhalers? They may not want to as well. And indeed, I had a patient last week who was adamant that they could not possibly leave the house without their blue inhaler because they're so reliant on it. And that may well just be the case. And we're not expecting 100% here. But I think you have to follow the evidence and follow the guidelines here. And we need to move into this SABA-free future because SABA alone is demonstrably dangerous, and we've known now for the best part of 40 years. And now we can do something about it. So Arlene has mentioned most of this already, but I think we can try to intervene here in the acute service when people come with exacerbations or they come to ED, AMU, out of hours, and to pharmacies. So I've met with our critical care colleagues. I met with out of hours yesterday. I've met with some pharmacy colleagues, and I'm meeting with ED next week. So we're going to try to have a uniform strategy of how you might take someone who's at very high risk or a new diagnosis and give them the right information. There's a lot of routine review that goes on with the asthma specialist nurses of the community, with practice nurses, and also with pharmacy. I think we need to really recognize how much contact community pharmacists have because they're the ones who are giving out these inhalers on a regular basis and they're reviewing scripts and they can pick up on so much. And then there's big opportunities here for anyone out there who wants to do a bit of quality improvement work, a bit of audit, do some research. We've got plenty going on. So if you're a resident doctor or indeed anybody who wants to get involved with some QIP work, where this is a really ripe area to do that in. Again, my animations have gone wonky because of transferring across things. But in the asthma pathway, um, not all routes lead to a severe asthma centre or a severe asthma specialist, but there are some things which should trigger you to referring on to us. And that's people who are having multiple exacerbations requiring lots of oral steroids, and picking that up is important. Anyone who's on maintenance oral steroids, and that does still happen, really needs to be referred to the severe asthma service as soon as possible. From our data, which we've collected across Scotland in the last couple of years, about 30% of the patients we see in severe asthma centres across Scotland are on maintenance steroids, um, uh, which is very concerning. And then rescue packs are a red flag. People who are on rescue packs for asthma, and this happened a fair bit because of COVID, lack of access to primary care and emergency services during COVID. So people were given rescue packs so that as a reassurance at home. But rescue packs are really not a great idea and lead to steroid overuse. And that's an entirely separate 2 hours of presentation, which is my personal hobby horse. But I'll not talk about that too much right now. But if you are in an acute service or you're in primary care and you're worrying, who are the people you worry about in asthma? Then it's people who exacerbate a lot, get lots of steroids, maintenance steroids, and people who are overusing rescue packs. So I promised you a sort of after mid-credits scene to whet your appetite of something else, and this is severe asthma. So um, the mild, moderate asthma should be dealt with by AIR into MART, and then for MART, there are some add-on therapies to think about. But it's really how do you go separate out the mild to moderate asthma patient for the severe asthma patient that we're really worried about, that is using lots of steroid and is at a really high risk of dying. This is what we understand of the asthma pathway, and I'm certainly not going to labour this point. But if I'd drawn this diagram 20 years ago, it would have not looked like this. Our understanding of how asthma works at a cell at the epithelial level is so much more detailed now, and we're able to have targeted therapies, monoclonal antibodies, essentially that work at either IL-5, IL-4, IL-13, TSLP in the main, that are incredibly effective drugs. They're not cheap, but they're cost effective in terms of reducing steroid burden in the long term and reducing admissions and exacerbations in the long term. And we have had these since about 2019. We have 2013 for
Who's
omalizumab 2013. I'll give that. But then in the main, this has been sort of the last sort of 6 years of the bulk of them from the IL-5s. And we have 350 plus patients in Tayside on biologics, and I'll show you that we probably ought to have about 1,000. There's so much asthma about, and about 80% of people with asthma will have what I've sort of labeled here as benign asthma. It's not benign in terms, people have symptoms, but it should be easily treatable by AIR and MART, because their amount of inflammation and their amount of symptoms is fairly concordant. And if you suppress their inflammation in their lungs, their symptoms get better. And these people don't tend to exacerbate too much. And so long as you've got them on some steroid and they're not on SABA alone, they will do well. Then you have a group of people who have concordant severe asthma, and that is that they have a lot of inflammation, very high eosinophils, lots of FeNO, lots of IgE, lots of active inflammation, and they have lots and lots of symptoms. And these are the patients that we want to see in severe asthma clinic, because we know that if we suppress their inflammation, we bring down their symptoms and move them away from the severe cohort group. There's an interesting group who have lots and lots of inflammation, but have little in the way of symptoms. And we don't really have a term for that. I call it silent asthma. It's the people who swear blind they don't really have asthma. They don't take their preventer inhaler because they don't really think they've got asthma, but they take their blue inhaler a lot when they get symptoms. But they have so much inflammation in their airways that when they exacerbate very strongly. And those are the really worrying group that we're hoping to deal with by using AIR, because they'll no longer have SABA over reliance. There's an entirely separate group who are called difficult asthma, who have a lot of symptoms but not much inflammation, and that's a group of patients that is really very challenging, and is again a separate talk all in itself. But the people we really want to try to pull out here are the concordant severe asthma patients. This is data from 15 years ago showing that severe asthma is not new, and at the time there were very few severe asthma centres, but the patients who came to the severe asthma centres were on a lot of steroid. 40 to 50% of them were on or maintenance oral steroids. They were on moderately large doses, 15, 13, 15, 10, and 15. Large doses of inhaled steroids. They were using a lot of SABA, and then there was a big mixture of different drugs that were being used, including, frighteningly enough, cyclosporin for asthma. So 15 years ago, we recognized this severe cohort of people with asthma, mostly being treated with a lot of steroid because there was no really other option. But the dangers of steroids, I suspect, this is no surprise to any of you, that long-term steroid use leads to osteoporosis and thin skin and easy bruising and cataracts, etc., etc. But it may be a surprise to you to know about the acute effects of steroids. This is data from 2017. It's American data, but I think it's fairly transferable across to here. That if you look at patients who've had a short course of steroids, and by this the median dosing was 6 days, and the dosing was not that high, so overall the doses of sort of 20 milligrams, then the risks of sepsis within 30 days, it has an incident rate ratio of 5, and over the next 3 months it's nearly 3. And the risk of developing a venous thromboembolism, DVT-PE, is again 3 and 1.5, and fracture is 1.87 and 1.4. The dose we give for asthma is 40 milligrams for 5 days, so that gets into this group here. So people who are getting 40 milligrams or more have an odds ratio of developing sepsis within the next month of 5. And we give out steroids to people as though it's a really benign sort of thing. Most people, I mean, a lot of people with asthma who I see in clinic say, "Oh yeah, I get 3 or 4 courses of steroids a year, and that sorts me out, and it's fine." We've completely normalized that. in our practice across the in the UK, I think. And if you look at COPD, we give even more steroids with even less indication in the COPD group, and they are usually more frail, higher risks as a baseline, and yet we give them large doses of steroids for a long time. So this was very, very worrying for me, and explains a lot about why people often present to us in AMU with pneumonia, having had 2 or 3 courses of steroids in the previous month, because their risk is being racked up by the amount of steroid they get. The long-term risk of steroids is well documented. This is just a fairly recent review looking at the type of side effects that we were all taught in medical and nursing school of what things you get if you take lots of steroids. But the interesting thing here is that the risk stacks with lifetime dose. So if you've had less than 500 milligrams in your life, then which is the top lines, then your risk is often not too bad. But by the time you've taken 2,000 milligrams in your life, then your risks go up quite a lot. And you think, well, 2,000 milligrams seems like a lot. But for your standard asthma patient who might get 1 or 2 courses of steroid a year, you only need 5, quotes, well-controlled years before you racked up 2 grams of steroid. And then your risk of an affective disorder has gone up by about 1.5 to 2. And then it continues to stack as you get more and more steroid. We know the patients that struggle the most in our clinic are people who have obesity, people who are hypertensive, people who have affective disorders, and multimorbidity, many of which are caused, at least in some part, by the amount of steroid they've had by the time they reach us. So case finding is really important in severe asthma. This is the Scottish severe asthma pathway, which I chaired the group on this over the last sort of 4 years or so with colleagues across the whole of Scotland, and we're updating this on a fairly regular basis. And the criteria to think about severe asthma are lots of SABA usage, 2 or more exacerbations requiring steroids in a year, or you can do some quality of life scoring, which are validated questionnaires that are easily reproducible in primary care. People who have 3 or more exacerbations in 12 months need to be referred urgently to a severe asthma clinic to come and see me, Rory Chan, or Brian Litworth. The 3 of us run the service together. There are some other things in here looking at how high your IgE is, how high your eosinophils are. Certainly if you're on maintenance steroids, if you think you've got ABPA, all these things pull together to lead to an urgent referral. We have a regular MDT every week on a Monday for patients who we're considering for an asthma biologic, and so long as they meet the requirements, then we start people on biologics every single week. We have a comprehensive data set. We collect data on this, and we've presented it locally, regionally, and nationally. And Rory Chan is now leading nationally on a project to collect data for the whole of Scotland, so that we can get better governance and answer some questions about our biologic use across Scotland. And I will drag him to Grant Rounds next year to present on it. But what we're trying to do here is change our way of managing people from phenotypes into endotypes. So we know that we can try to assess phenotypically what our asthma patients look like by measuring things like eosinophils and FeNO, people who have multimorbidity with chronic rhinosinusitis with nasal polyposis, which is a horrible acronym, CRUSNIP, atopy, aspergillus, vasculitis, all these things we know generate certain phenotypes, but we're now moving into what endotype are they, because it helps predict the response to the treatments, and these are the MABs: omalizumab, mepolizumab, benralizumab, dupilumab, and tezepelumab. These are all very, very effective drugs, and it's nice when people come back to clinic and tell me that their lives has been changed, and they genuinely say these are life-changing drugs, that they didn't realize how well you could be, and they didn't realize that you could go more than 6 weeks without having steroids. And we've got about, I think, nearly 300 of our patients who are on long-term successful patient-initiated review, virtual review, who are exacerbation-free, having come in with at least 3 exacerbations a year. So that's really, really positive stuff. It's complicated. We look at all these kinds of things. If you're interested in the cellular biology of asthma, then come and talk to me. I'll talk to you all day about different cytokines in the lungs. But essentially, we take all of that into, and all that's on the screen here, to try to change symptoms and exacerbations into phenotypes, endotypes, and treatments that we know are effective in severe asthma. But we can only treat people if they present to us. So the severe asthma pathway has these criteria, and we are asking our primary care colleagues to look out for people who had 2 or more courses of steroids. If you had 3, 4, 5 courses of steroids, then refer early, because in England and Wales, Hitesh Rapani and Gronyo Ancona's data, when they looked at this around COVID time, showed that the average time from referral from GP to getting a biologic in England and Wales was 7 years, which is a frighteningly large amount of time. So we need to detect people much, much earlier. We need to know to get people who are exacerbating frequently onto consideration for biologics. And as we said it earlier on in the talk, getting people who are overusing SABA onto AIR. We do a bunch of stuff when we see people in clinic, and sometimes people don't have asthma. It turns out they're being treated for asthma, what they don't really have. But most people have asthma with multimorbidity, and we can find a phenotype and an endotype, and we can improve their outcomes. I would say that probably 10% of people don't respond ultimately to a biologic, and we're left with that group of difficult asthma patients to manage. And again, that's another talk for another time. If you are interested in what we're doing with these biologic therapies, we have anti-IL-5 receptor, monoclonal antibody benralizumab, a combined anti-IL-4, IL-13 is dupilumab, tezepelumab is anti-TSLP, and omalizumab is anti-IgE. So they all work in slightly different ways, but they're all working on the Th2 pathway, different levels within that pathway, and they've all been shown to be very effective. How are we doing across the country? This is the data from of the horrible term biopenetration. How many people in our community are getting a biologic as a proportion of people who we think have severe asthma in that population? And Tayside is the best in Scotland. And this is the data from the prescribing guidance I showed you earlier on. We've got some other data shows that we're probably about even with Lothian, and perhaps the number is much better than 15% now in 2025 rather than 2022. But there's a long way to go. And as I said, we can only prescribe the drugs to the people that we see. So in an unusual quirk of secondary care presentations, we'd like to see more patients rather than fewer. These drugs have a few complications. Mainly, it's that they get arthralgia, and about a fifth of people on Tezi get arthralgia, about maybe 1 in 20 on dupilumab. And dupilumab also has some side effects that affect the eyes, but we screen for that and we warn people about it beforehand. And otherwise, it's just the usual sort of a bit of abdominal pain, nausea, or headaches, which tends to go away. And importantly, they're not immunosuppressant drugs. So we get a lot of questions about this, often from pre-op assessment or the surgical units or a different department. Say your patient has come into our unit, and should we stop their biologic? Should we give them prophylactic antibiotics? And the answer is no. As they are such specific targets of Th2 pathways, they don't increase the risk of viral, bacterial, or fungal infections. You can carry them on prior to surgery or having teeth out, and you don't need to withhold them during infections. And there's certainly no need for prophylactic antibiotics for uncomplicated asthma patients who are on a biologic. So that's actually very straightforward. We don't need to tell you anything particularly clever. It's just keep them going. So I have come to a conclusion. And so the main bit of this at the beginning was that the 2024 guidelines describe a SABA-free future. We accept we can't do this as a mass switch. It's going to take 3 years to get through the process, and but we can start this process now. AIR is straightforward, safe and cheap. You need just one of these and one of these, and you can train everybody how to take their asthma treatment. There are some people who won't manage it, but most people, the vast majority, will be fine on that. And we'll start with the new diagnoses, which is in the main going to be a primary care driven thing. We all have the opportunity to do opportunistic switching, and that could be anybody comes into pre-op assessment, comes into AMU, comes into the surgical unit, comes in anywhere. It could be people that you know who've got asthma, who you think would be better off on AIR. Then we should be encouraging the switch to the new evidence-based treatment. And then my post-credit scene, about severe asthma is please do think if you're seeing people who've had lots of steroids for their asthma, they may be eligible for biologic therapy. Long-term steroids and frequent steroid bursts are not the preferred treatment for asthma in the 2025. For more information about asthma, you can scan this QR code. It takes you to the Right Decision Service website, which has here on it the Managing Chronic Asthma. This is the new sign guideline in an easily readable format. And I think I mentioned this in the email, will be a plain language version of the sign guideline coming out in the next few weeks, which will hopefully help disseminate this information to all our patients. So I'm done. I'm grateful to Arlene for coming along and filling in the middle there. And so just to mention the whole suite of people who are involved in the MCN asthma group, all the pharmacy folk, everyone who's worked in any way towards this guideline, all our specialist nurses in secondary and primary care, our GP colleagues, everyone has put input into this because it is it's a paradigm shift. It's a generational change in how we treat the most common respiratory illness. So I'm grateful to all of them and look forward to seeing the changes happen. So it looks like at least a couple of people have hung on till the end. So there are some questions. Sarah's, is that true instance or diagnosis? I don't know, Sarah, but I'm sure you can badger me later to try to I can look into that for you. Karen has said, why was Symbicort chosen as the inhaler of choice if it's the worst environmentally? It's not the worst environmentally. Symbicort MDI, which I do have one here, which looks like this, is not great for the environment. But we're not supporting that one. We're supporting the Symbicort DPI, which is the turbohaler, which has a very good carbon footprint, a very low carbon footprint, because it has no propellant gases in it. You may have noticed if you're at clinical on the wards, there are now some inhaler recycling boxes. They look like Sharps boxes, but they're purple, and they've been dotted around in various bits of the hospital now. So you can drop these into there, and whatever is recyclable will be recycled. But so Symbicort DPI is good, Symbicort MDI not so good, and we don't support that one. A few patients have had severe cramps, dose dependent with Symbicort. Where do we go next? I would say you go to Lufebec and give them MART. The problem we have with AIR is that the licensing is for Symbicort or for Spiromax Duraresp or for WalkAir, although WalkAir has been removed at the moment from circulation because of a manufacturing problem. So we're limited by the license indication, but it is likely that there will be Me Too applications for these drugs so that most of the formoterol containing inhalers will be available for AIR in due course. But for now, if they really can't tolerate Symbicort, I would give Lufebec MART, one inhalation twice a day in PRN. Thomas Downs has said, what's the availability and typical wait time for a pheno in Scotland? It's a great question. And in Scotland, there are single digits, count it on one hand, number of pheno machines in primary care. From before the guidelines came out, I have lobbied Scottish government along with colleagues to say, what are we going to do about funding pheno machines in the community? And I don't have a definitive answer for you for that, I'm afraid. But on a health board and HSCP level, where I am in discussions with both to say, how can we get more pheno machines into primary care, maybe into CTACs, maybe into clusters. If you're watching this in primary care and thinking, what can we do about pheno? They're not that expensive, and as long as you buy the right machine, the consumables are quite cheap, but they're a very, really valuable test. I would probably argue that it's more useful than having a spirometer, and anyone can do it. I've had 2 adult patients in short succession with significant wheeze and auscultation in the context of viral and bacterial LTI. One has been given salbutamol inhalers many years ago for wheeze and a chest infection. The other had never had wheeze before. Neither had a diagnosis of asthma. And here is the problem, that people get given a salbutamol inhaler because it's a relatively benign treatment. Yet we know that if you take SABA by itself, your risks go up, regardless of what your underlying diagnosis is. Would you give a salbutamol for both? No. or Symbicort for the one with previous infection-induced wheeze, and which was helped by salbutamol and followed up for query asthma, or do something else entirely. So I would give them both a Symbicort inhaler and say take that when as and when you need it. And if they never don't need it anymore, then they won't take it because they don't need it anymore. But if they do need it, then they'll take it, and then they get some steroid on board. And I think you label them as having asthma. Um, and if you have challenging things like this, then I'm very happy to receive advice through receive requests for advice over on Sky Gateway, or you can email me and I'll try and help you out with these things. I have a meeting with the community nursing colleagues the third Wednesday of every month at 1 o'clock over Teams. And if you would like to join that, then I can give you the link and you can come along and fire these sorts of questions at me. I'm very happy to receive that. What about use in pregnant patients? There is no specific guidance in the new guideline about treatment in pregnancy. Over and above, the treatment, sorry, my phone is ringing. Over and above, treat patients as you normally would. So there's nothing in this that would say don't give it in pregnancy, as in AIR and MART. And in fact, MART has been available for a long time. So our advice is to give MART or AIR in pregnant patients the same way. The overriding message for treating asthma in pregnancy is that a happy patient, as in the mother, leads to a happy baby. So the most you can do to make the pregnant woman as well as possible is the best thing for the pregnancy. A couple of people saying thank you. That's my pleasure. Somebody's asking about AstraZeneca doing quite well from Dix. What has been their involvement in developing guidelines? Locally, they've had no involvement in it whatsoever. So they had they did a lot of the research into AIR was funded by them. But the European Respiratory Society, the British Thoracic Society, have all reviewed all the data and supported it. And like I say, it's not just Symbicort that's licensed for this. You could use Spiramax, Duoresp, and the Walk Air inhaler, but the best inhaler device, in our opinion, was a Symbicort inhaler. So that's what we've gone with. From my point of view, OCS and inhaled steroids are associated with long-term adrenal suppression, and they absolutely are. We unfortunately see too much of this. Patients who've been on long-term oral steroids or pulsed oral steroids, even with biologic therapy, we get them weaned down and they're still left with adrenal suppression, which is a real disappointment. Because we know if we caught them earlier, we could have probably prevented it. Peter Oates says, is the association between high use of SABA and increased mortality causal, as it hastening is a marker of poorly controlled asthma, which turn increases mortality? We think it's a bit of both. I'd encourage you to read that Sammy Sweeter's review of this, I think in 2002. He's an incredibly good statistician in Saskatchewan in Canada, who's done a lot of work on this. And his view is that it's a bit of both, in that it is probably a marker of poor engagement with treatment overall. But even when you try to adjust to that as confounders, you still end up with a signal, and that excessive beta agonist, constant beta agonism, as in a high adrenergic signal, is detrimental. So we think it's both. Interestingly, there was some data from America in about the turn of the millennium, maybe a bit later, maybe 2002, 2003, looking at long-acting beta agonists used in isolation. So a LABA without a steroid. Because in America, where you have to pay for both, people were paying for their LABA, but not paying for their ICS. And particularly in people of black and ethnic minority, particularly black-skinned people, there's definitely a signal. For if you have LABA by itself, you have an increased cardiovascular risk of death, not just an asthma risk of death. As you can tell, you've asked me a question, I start rattling on because it's very interesting, but it's a great question. Charlotte has said, that's what I did, gave both Symbicort after your GP evening of it, got challenged that this was wrong as no diagnosis. It was a misinterpretation of the guidelines. Okay, fine. So I don't think it's a misinterpretation of the guidelines. Think you should get, and the previous guidelines would have supported you as well, Charlotte, because you would have said, I suspect this person has asthma. I will therefore give them an ICS. It's just we don't give ICS plus a blue inhaler. We now give Symbicort. Okay, we have overrun. Some of you have stayed along. Um, it's um, it's quite a privilege to introduce myself at Grand Rounds and then have an hour to talk about my favorite topic of asthma. So thank you very much for staying on and listening. I appreciate you very much. And we'll be back next week with another Grand Rounds where I will speak for only 3 minutes and somebody else will go on. So thank you very much, everybody. I hope you have a good afternoon and the sunshine stays for the weekend. So take care and see you next time.